Okay.
Ready? Okay. So our first speaker is Dr. Patricia Kavanagh, and she's an Associate Professor of Pediatrics at Boston University School of Medicine, Boston Medical Center. She has a national reputation in using systems approaches to improve the care of children and adults with sickle cell disease in the emergency department setting. As an attending physician in the BMC Pediatric ED, she has colleagues defined and refined treatment standards for children with sickle cell disease. She has similarly worked to improve care for adults with sickle cell disease in the ED through guideline-based care pathways and the use of individualized pain protocols. Her current grant activities include studying the impact of screening and referring families with unmet basic needs on health on outcomes for children with sickle cell disease, and serving as a subject matter expert in a multi-site randomized trial comparing individualized pain plans with weight-based protocols. Nationally, she co-founded and serves as chair of the Emergency Department Sickle Cell Care Coalition and serves on the Oversight Steering Committee of HRSA's Sickle Cell Disease Treatment Demonstration Program and the Steering Committee for the American Society of Hematology's Sickle Cell Disease Coalition. She completed her pediatrics residency at Boston Children's Hospital and Boston Medical Center, and a fellowship in General Academic Pediatrics at Boston University School of Medicine, Boston Medical Center. And before I turn this over to her, I want to thank her. And when I asked her to do this, she overwhelmingly said, yes, I'm ready and willing. And we really appreciate Dr. Kavanagh kicking off our symposium today.
Thank you so much. So the one thing I'll ask is the ability to share my screen. I think I'm disabled. It might be for you. But I can at least get started by saying thank you so much for that really wonderful introduction. The one housekeeping slide I always start with is any conflicts, and I do not have them. Oh, great, thank you so much. So I don't have any conflicts of interest. I do have several grants, but let me start this presentation. And there we go. All right, can everyone see my slides? Yes, okay, great. All right, so so my talk today is that sickle cell disease in the ED, we must do better. And we will. So I just, as I was starting to say, you know, for conflicts of interest, I really don't have any. I do have some current grants related to addressing social determinants of health for those with sickle cell disease. I have one that I work with Paula Tanabe, who she will describe. I'll leave it to her expert hands. And I'm also involved with the HRSA Sickle Cell Disease Treatment and Demonstration Program grants. I'm also involved with two sickle cell organizations, one that I'll mention later on in this talk, the Emergency Department Sickle Cell Care Coalition. And then I'm also a steering member committee for the Sickle Cell Disease Coalition of the American Society of Hematology. So, and my area of expertise is the ER. So the objectives for today are really to describe sickle cell disease and acute complications requiring emergent care. The second objective is to examine the barriers to high quality care for those seeking emergency department care. I'd like to give examples today of interventions that have been used to improve care for those with sickle cell disease, and then outline actions that are underway to improve ED care for all persons living with sickle cell disease in the US. So the first is, you know, I wanted to just give a little bit of a background. What is sickle cell disease? And the one thing I always highlight when I'm talking, especially to residents and even other colleagues, in the right-hand corner here, I am not a sickler, right? Sickler is to me, is a disease. It is not a person. So sickle cell disease is a disorder of hemoglobin, and it's a disorder of one copy of the beta globin sickle gene that if you have sickle hemoglobin, and if it's paired with anything other than hemoglobin A, which is a normal adult hemoglobin, it results in sickle cell disease, but it's a one misspelling that leads to sickle cell. For sickle cell disease and sickle cell trait, approximately 5% of the world's population carries trait genes for hemoglobin disorders. And the most common are sickle cell disease and the blood disorder called thalassemia. Sickle cell disease affects approximately 90 to 100,000 Americans, occurring in 1 in 365 Black births, and less common in Latinx births, but it's still something we definitely see, especially those coming from the Caribbean and Central America, and also in Brazil. About 1 in 13 Black babies is born with sickle cell trait in the United States. But when you look globally, it's much higher in certain parts of the world, including, we always think of sub-Saharan Africa as the area where sickle cell disease is most prevalent. But we now, especially in the last 15 years, understand that India has a sickle belt, a sickle hemoglobin belt. The Arabian Peninsula has a lot of sickle cell disease, and other parts of the Mediterranean, including Italy and Greece. So this is a very common disease, a common gene around the world. And then I wanted to spend a moment just talking about what does sickle cell disease do within the body. And so the graphic on the right here is a picture of a capillary. And when I was in medical school, I learned that the issue really was with only the red blood cells. So in the lower part here, you can see these red blood cells. They are not as squishy getting through these small capillary beds as other red blood cells may be. And so they cause damage to the inner lining of these tiny blood vessels, capillaries. So when I was in med school, we learned that what happens is the red blood cell goes into these capillary beds, there's less oxygen there, and then they start to sickle and get clogged up. In the last 10, 15 years, we now understand that that's only part of the story. And actually the big player that we didn't know about is that when there's damage to the lining of the blood cell, it's the white blood cells that actually get very interested because they think there might be a problem. When the lining of a blood cell, of a capillary is damaged, they think that might be an infection. And so instead of rolling along as they normally would, they actually start sticking. And you can see here with the circle around it, this white blood cell is putting up different receptors that is catching red blood cells and causing the occlusion. This is important just because that's why there's so much interest by pharmaceutical companies, because all of these different interactions are areas where we can intervene, potentially giving more therapeutic, more medicines to treat sickle cell disease than we currently have. Because right now we really are limited to about 4 or 5 different treatments, including hydroxyurea, transfusions, crizolizumab, and voxelotor. But when you think of other diseases, there's usually pages, right? So this is wonderful to know, and ongoing work is occurring, more research. The acute complications of sickle cell disease. So I think, too many people think that they equate sickle cell disease and severe pain, which I don't want to disabuse them of. But why is this an emergency when someone comes in to the hospital, to the emergency room? They need to be evaluated for a whole host of other things, because acute pain crisis is a diagnosis of exclusion. You have to run through your checklist of what are the other things it could be and make sure it's not. So the other things it could be, we need to check for fever. So those with sickle cell disease often lose the function of their spleen in childhood. And so that leaves you open for severe infection called sepsis. Chest pain in sickle cell disease is really concerning because it could represent acute chest syndrome. It could represent pulmonary embolism, even in younger, like in teenagers. I've seen it in our ER in younger people. Headache is not a migraine until you've at least thought about stroke, especially this one form called hemorrhagic stroke, which causes severe headaches. And it's most common in adolescents and those in their 20s. And then obviously if you have other signs of stroke that we think of in older people, this can happen in young people as well. Abdominal pain in sickle cell disease is tricky. You have to think of the gallbladder. Our, acute splenic sequestration is where the spleen fills up with sickled red blood cells and can cause severe pain, or it can even be in your liver. It's less common, but you can have a sickling event in your liver. So I'm always teaching people when someone comes in with abdominal pain with sickle cell disease, there's a lot of things we need to think about and explore. And then priapism, a painful erection. A lot of young men who have this, it's really embarrassing, or even younger children. So they often say they have abdominal pain or thigh pain rather than really isolating the location of the pain until they're in a room, a little bit more of a private setting, that they can really disclose where the pain truly is. Chronic complications of sickle cell disease. I'm sure many in the audience know a lot of these, but just feel like you can't give a talk about sickle cell without reviewing it. This is a multi-system disorder. Can affect other, bones in other ways. Often sickle cell pain is located to bones, but that can cause osteonecrosis or avascular necrosis of the joints, primarily the hip and the shoulder. It can cause damage to the brain as well. And so if you've had previous strokes, or even in children, we see that there's teeny tiny little strokes that happen that we don't see evidence of, but if you do MRIs, you can see. And over time, that can lead to issues with memory and even just doing daily activities. Kidney function is affected. Obstructive sleep apnea is common. Pulmonary hypertension. So we think about, measuring our blood pressure in our arm. This is basically the blood pressure in your lungs can be affected, especially those who've had acute chest before, can end up with issues with pulmonary hypertension, eye disease, retinopathy, leg ulcers. And then if you're on chronic transfusion, iron overload. So sickle cell disease, multi-system, very complex. And when they present in the ER, all of these must be thought of. It's not surprising that mortality in sickle cell disease is high in young people. And so this is data taken from the CDC from records in California. And they find that the overall, a median age of death, so what is the midpoint, is 43 years. So that means half the population lives longer, but half the population does not even live that long. So we have a lot of room for improvement here. So the next part of my talk, I really wanted to talk a little bit about the challenges facing children and adults living with sickle cell disease when they are seeking care. So just to give more of a backdrop of what are some of the other challenges. The transition from pediatric to adult care is difficult. In the pediatric care setting where I work, their children with sickle cell are more likely to receive care in an academic center. They're cared for by practitioners who are pediatric hematologists, oncologists. So they have a lot of services for patients and families, including social work, mental health. There's one board exam for these practitioners. So they are expert in both hematology and oncology, which leads to more services around the country. Still not perfect, but there's still a lot more of them than when you go to the adult world. There are not enough adult providers with expertise in sickle cell disease. When you're talking about training, the fellows who are in training for becoming board certified, they can choose whether to be a hematologist or an oncologist. In the adult setting, there's very few that maintain certification in both. And many, frankly, choose oncology because there's a lot more money in it. And when you're graduating with loans, I think that's something that people take into consideration. And the ED care is very different. So when in the pediatric setting, there's some emergencies, absolutely, trauma being one, but sickle cell disease doesn't have as many things to compete with. When you get to the adult setting, you're thinking about stroke, heart attacks, and elderly are more the concern rather than younger people who are perceived wrongly in this case, as healthier. And there's just a high volume of complex disease. And the issue is that sickle cell disease is often not on the minds of those who are taking care of these patients. The current state of adult sickle cell care is fragmented at best, and non-existent in areas at worst. So I created this slide back in 2008, and I am sad to say I don't think we've made nearly enough progress in this. What happens is that the outpatient setting, you may have a good hematologist or even a primary care physician who understands you, who understands your disease, who understands what is going on in your life. And then you go into the inpatient setting, whether it's the emergency department, into the hospital, going to get surgery, and you feel like you're starting all over again. The communication is often not very good at all, and sometimes non-existent. Whereas in the pediatric world, I can't touch, well, I can't decide what a child with sickle cell disease is doing when they come to me in the ER. I always run the decision about sending them home versus admitting them to the hospital past an expert. In the adult world, that often is not happening, even in academic centers. They're really relying on the ED staff to make that decision. And then communication about what happened and what was the plan is often lost. There's also a lack of research for sickle cell disease. This paper was published just last summer, and it showed that the research funding difference between sickle cell disease and cystic fibrosis, which affects largely Caucasian population of Northern European descent, there's a 10-fold difference between the two. So we think that race and bias does not play a role. I would argue very strongly that that's not true. There's some systemic racism here. And the sad thing is this funding differential has actually increased since the study was published in 2006, which showed a 9-fold difference. So there's a huge issue, and it's not changing at all. So cystic fibrosis is getting even more money. There's more, we're making huge strides in survival. And sickle cell disease, we are starting that journey, but we are still lagging behind. And poverty in sickle cell disease. This is something that's not brought up enough. So this study was published back in 2019, but it clearly shows that there is so much cost associated with having such a significant disease all of your life. So as a child, your parents are trying to take care of you while holding down a job. It's hard though. This is an unpredictable disease. So taking time to go to the hospital, to the emergency department, you often will lose that job. As you become an adult, it's even worse because trying to take time off if you have a crisis, you're not sure how long you're going to be in the hospital. And even when you go home, you still have pain or you're still dealing with some of the effects of it. So job security is non-existent. And too many of our families live in poverty because of this, because of they're underemployed or they're unemployed due to their sickle cell disease. And it's compounded by the fact that they are not able to reach the same education attainment as others. A lot of folks really struggle to go to college and then really complete it. I'm proud to know several young adults who took 6 or 7 years to finish their degree, but they may not have finished in the degree that they had originally started in because of stress, because of the demands that were needed. So now I want to really focus on what the tone of today is. Why is improving ER care? Why is that so critically important? And so as we saw in that video, we're starting to really talk about, I always want to mention, what does it feel like to have a sickle cell pain crisis? I've never experienced one. I've witnessed them, and it rips my heart out every time I see it. I think the first time I really started to get a sense of it was a young woman told me she had twins, and she actually didn't go to the hospital soon enough, so she delivered her twins naturally because it did not compete or compare with her sickle cell pain. When I thought of that, it really struck home that this is one of the most severe forms of pain you can ever experience. And so just as we saw in the video starting it off, These are the quotes that came from this citation, Sickle Cell Anemia News. It feels like being stabbed repeatedly while having a migraine throughout your entire body. Some noted it feels like you have multiple fractures, multiple broken bones and glass flowing through your body. For me, it's like taking a rubber band and tying it up on your finger over and over and over again until you can't anymore. Leave it on for a few minutes and then take scissors and snap that rubber band. And that feeling when your blood comes back in, that stabbing pain that you feel in the finger for a split second, plays on your joints nonstop until you have the main painkiller kick in. And the fact is, we need to improve ED care because individuals living with sickle cell disease rely on us as they get older. It is a fact of the disease that it does get worse with time. It is the constant hum of the sickle cells flowing through the body, as Wally Smith would say. It's constantly wreaking havoc. And so it is no surprise that as you get older, you're going to have more issues that need acute care. This is a graphic that just shows emergency department reliance, which is total ED visits divided by outpatient plus ED visits. And it doubles from the age of 15 years to 22 years. So we can see that there's a big spike there. Disease is one part of it, but I do believe that the other key factor is that the transition from pediatric to adult care is not smooth. And a lot of patients do not feel like they have any other alternative but to seek care in the emergency department until they get through that hump and really start establishing adult care. This is another piece of data just showing that in California and Georgia, ED visits for those aged 20 to 39 years accounted for more than half of all ED visits by sickle cell patients. Why does improving ED care matter? In deciding to come to the ED, individuals with sickle cell disease have to make a choice. It's death versus dignity. And when I heard this, I didn't think I could be shocked at any more than that, but I think this encapsulates exactly why we're all here today. This should never be a choice that anyone should be thinking about when they seek care in the hospital. It actually is shameful that we even have to, that we hear this about our care. We need to do better. The general perceptions about patients living with sickle cell disease. This scale was created by Carlton Haywood, who is an individual living with the disease himself. And it really just it highlights and encapsulates all of the attitudes that people have towards those living with this disease who do not understand just how bad it is. So some of the negative attitudes is that patients over-report or over-exaggerate how much pain they have. I just explained to you that my friend had twins and didn't even compare to her sickle cell pain. There is this misperception about drug seeking that there's a lot of substance use in this population, and that is just not true. That you're manipulating people to get more medication than you need, which is just not true. And when concern-raising behaviors, when patients are requesting a specific medication and dose, just as that woman asked for, those living with sickle cell disease, what you need. You are very experienced with the healthcare system and know your body's best. And yes, you actually do know which medication you need and what dose, yet we penalize you for it. And so when the patient has disputes with staff, again, this is when patients are trying to advocate for themselves. When you're in pain, you're a little bit more aggressive. We all are not having a good day. And so when staff don't believe you or they are arguing with you that you can't possibly need that much medicine, it's just ripe for conflict. And red flag behaviors, that the patient changes his or her behavior, that they appear in greater distress when the provider walks in the room. It's because some patients feel like they have to convince everyone who has never experienced a sickle cell crisis just how bad it is. The history of signing out against medical advice. I've known too many people who've done this because they feel like, this pain is so terrible. They're treating me so badly. I would rather leave and go home and die rather than spend one more minute in the hospital. This is why we have to change. We have to improve our care. What signs or labs reliably confirm a crisis? Nothing. It is patient reports. And that's why a lot of the work that you're going to hear about today is being done, because we have to listen to our patients and learn from them. And we know that sickle cell care in the ED is suboptimal. This study was done 8 years ago now, but they looked at patients who were coming in with sickle cell disease with the pain crisis versus the general population. And those with sickle cell disease waited 25% longer for pain medications. They compared a group of sickle cell patients with those with long bone fractures. So like you have a bad arm or leg fracture, and the wait for pain medications was 50% longer. And this was after they did statistical adjustments for race and how much you were prioritized at triage. So this is real, and we have to fix it. So this was me probably back in 2006 when I was first faced with this decision of what can we do? And there's a lot we can do. And so hopefully today you'll learn about many things, not just what I'm going to share with you, but what others have done as well. And so I think the big message is that there's a lot of us who are getting to work, who are working hard to improve sickle cell care in the ED. One of the most important things is that we must add sickle cell disease to the list of priorities to the ED, especially for the adult centers. Because we always think about, when we think about acute heart attacks, right, we can get somebody in the emergency room from the door to the cath lab, right, where they can go and dissolve that blockage within an hour. The time to this one medication for stroke called TPA, we now have measures of quality saying that we need to get from time of arrival to the time of TPA within 4 hours, right, or into a neurology suite so that they can dissolve clots. Sepsis, we're expected to give antibiotics within an hour of arrival. Even the opioid epidemic, the EDs have really been working hard, and a lot of EDs, including mine, we are often starting people on Suboxone or other medications to help with their opioid addiction. So the ED is equipped to actually take excellent care of complex conditions that need multiple people to weigh in. We just need to add it to the priority list. And so the guidelines to manage acute sickle cell pain have existed for a long time. The first set of guidelines were published in 1999 by the American Pain Society. NHLBI, the National Heart, Lung, and Blood Institute, published their guidelines in 2003. This is not new. And so the guidelines, and they've been revised and basically republished for acute pain a couple of times over the last few years. So number one, if possible, use a sickle cell specific hospital-based acute care facility, such as a day hospital, if you can, to manage acute pain. So if it exists, get people out of the ED. It's chaotic. It's not a place to really be when you're in excruciating pain. If that's not available, then in the ED, you must be triaged as a high priority. So for example, an ESI2. So for those in the trauma bay, bad car accident, you're having a stroke, you're having a heart attack, and we know it. That's an ESI1. But those at the next level where they're very acute and you need to figure out what is going on, that's an ESI2, and that's where sickle cell disease belongs. And we need to do that in order to check for other complications, such as stroke, severe infection called sepsis, acute chest syndrome, etc. We need to treat pain aggressively. We need to get access and begin analgesic management within 30 minutes of triage or 60 minutes of registration. So door to drug time of 60 minutes, that is the standard. And if you are having trouble getting IV access, considering alternate routes to meet this measure. Consider giving, and then we're supposed to be administering IV opioids every 15 to 30 minutes until pain relief is obtained. And really stressing the use of other ways to help with pain, whether it's heat, any forms of distraction, whether it's music, talking to friends and family, Instead of penalizing somebody and saying like, oh, they must be comfortable, they're talking and laughing with a family member. We know the power of distraction when we think of women giving birth, right? There's always music. They're always trying to, have them talk to folks to really try to put them in a zone where they can manage their own pain. And then the final is to begin a patient-controlled analgesia for those who need admission to the hospital, just to prevent any gaps. If you're giving a lot of pain medication in the ED, the worst thing in the world is to have a gap in care. So we really want to continue the pain medications. By starting it in the ED setting, there's no lapse as you're being admitted to the hospital, to the wards. So I'm going to talk about a case study work that was done in my hospital at Boston Medical Center. So a little bit about us. We're a 487 bed inner city hospital. We're the largest safety net institution north of New York City. Our motto is exceptional care without exception. More than 80% of our patients actually are on Medicaid. We have 24/7 interpreters for the 3 most common languages, not other than English, spoken among our patients, which includes Spanish, Haitian Creole, and Portuguese Creole. And the opioid epidemic is at our doorstep. So we are basically in the center of it. We all carry Narcan. A lot of the providers, most of the ED providers carry Narcan, and I've used it because it is so prevalent. We're a level 1 trauma center. We have 140,000 visits a year, so we are a large, busy ED. We're also a comprehensive sickle cell center. Since the 1970s, we've been taking care of half of the children and the lion's share of the adults in Eastern Massachusetts, Southern New Hampshire, and Northern, and even some folks from Rhode Island come and see us. How I got started was by talking with patients, adolescents in particular, and their families. And so I did a qualitative study when I was still learning how to do research. And I started in our hospital, but then I spread it out to the other 3 institutions in Boston and really asked questions about their care. And universally, the one area that people had the most concern about was the ED, regardless of institution. One adolescent put it best, that he just did not understand the variation in the care. He said, I've had sickle cell disease my entire life. I go to the same ED, to the same hospital each time. And every time I go, it's very different. Sometimes I'm brought in and taken care of right from the outset, given IV opioids quickly, and everyone seems to know what they're doing. Other times, he says that he's explaining himself over and over again, that they're calling the hematologist even before they would do anything, including placing an IV. And he just did not understand why the care could be so different depending on the providers. And that really struck me, that should not really be happening, especially in the same institution. So for us, we decided to improve the care in the pediatric ED, and we would need to change our practices. In order to even start to figure out where we should begin, we created a multidisciplinary team. And so we pulled in ED folks, so nurses, doctors, also an ED pharmacist, because they understand what happens in the ED, how things are done. And then we also pulled in our hematology colleagues, so nurses, doctors, and social work, to really pull together plans and strategies that would make sense, that would best serve our patients. We developed a protocol based on the NHLBI guidelines, and we did a lot of education. But the nurses, we did face-to-face education with them, and the hematologists actually did a lot of it. I did some as I was working in my shifts. And then for the residents and the attending physicians, we did a lot of conferences, emails, just checking in and reminding. Our protocol looked like this. So everyone who is coming in should be triaged at a high severity level, so that they are evaluated within 30 minutes of triage. For children, we actually, with the suggestion of our ED pharmacist, we actually started our protocol with 2 doses of intranasal fentanyl to replace the first IV dose, and we can give it 5 to 10 minutes apart. We chose that because we were using it already when we were treating patients with long bone fractures, or if they had an abscess that needed to be drained. And so we actually got permission through the Pharmacy and Therapeutics Committee to just add sickle cell disease. They're coming in with severe pain, and we really wanted to give them medication quickly, and not, because sometimes getting IV access can be tricky. So we made that as our first line for our protocols, followed by 2 doses of IV opioids. And these are weight-based because children grow, and we give those 30 minutes apart. For those, when we're deciding whether they be admitted or go home, if they're being admitted, we start the patient-controlled analgesia, the pump with the button in the machine in the ED. If they're going home, we would actually give them a dose of oral medication that they would then continue taking at home, wait an hour to make sure that we actually did have good pain control before sending them out the door. Because we learned early on, like one time we gave some medicines, they were doing great, we sent them home. They weren't able to get to the pharmacy quickly enough, and the patient really had a relapse of pain. So we started giving this oral trial before we sent them home. And what you can see here is the results of our study, which we published in 2015 now. And you can see that the y-axis here is minutes, and then the x-axis I'll walk through each of these in turn. So the first couple of bars are the time to first opioid. And so the blue is the baseline period, which we took a lot of data 6 months prior to the start of our study. And then the red bars are after we did our intervention. And so our goal was to give that first dose of parenteral medication within 30 minutes. And you can see we were at 23, largely because of intranasal fentanyl. Giving a medication that you can squirt in the nose, you can do very quickly, basically putting the patient in the bed, getting them changed, and the dose of medication is right there. We also tracked the time to the second IV dose, just because we were worried that giving intranasal fentanyl, would they still be in the same urgency to get that IV placed? So we were worried it would actually delay that IV, and it did not. And in fact, the nurses told us we all knew the protocol. So we were giving the intranasal fentanyl, somebody else was placing the IV pretty much at the same time. And they just were able to follow along very easily. And that led to time, the decision to admit, instead of sitting for 6 or 8 hours before you would even decide whether to admit the patient, we were making it within 3 hours, because we would run through our protocol and see how the patient was doing. And for those going home, we were making that decision much quicker too, because if you're getting pain capture after a couple of doses, then you can see, give that oral dose, how are you feeling? You feel much more comfortable going home. And the number of children going home went up, which was so important to me. So when we first started our study, only 1/3 of children were discharged home. By the end, half of them were. But that's our experience at BMC. I was there helping run the study, but I'm going to show you that a couple more studies that showed very similar results. So Johns Hopkins started using intranasal fentanyl, and they published their data back in 2017, and they found very similar things, that their time to first dose was 29 minutes if they used intranasal fentanyl, but was well over an hour if they used IV. And the discharge home, this is a comparison between intranasal fentanyl of 45% for discharged home versus 48%. Oh, I'm sorry, this is admission. Forgive me. So this was no change, but they weren't admitting a lot of their kids anyway. They felt like they had a good system in place in terms of follow-up, so they didn't see a change. But when Emory took our protocol and implemented it, they did see a big change. Again, giving intranasal fentanyl is much faster than waiting for that IV for kids. And they were only admitting 48% versus 71% if you start with the IV route. And finally, a multi-center study, there was a randomized trial going on, and they just said out of the 20 institutions participating, take 20 charts, look at them, and 1/3 of the institutions were using intranasal fentanyl, 2/3 were not. And the comparison showed that, again, time to first dose was less than 30 minutes, And admission was 49% if you started with intranasal fentanyl versus 70 if you started with IV. This all hints at the fact that if you can really be quick and rapid with children with sickle cell disease, you can send more of them home than if it takes a long time. And I do think stress mounts when you're sitting in the ED setting. But what about adults? Let's talk about that. In the ED, we know that we have fewer competing priorities. Can this be done in the adult world? The answer is yes. So we did very similar work with our adults, ESI2, so evaluate quickly. We did use IV opioids rather than intranasal because the intranasal formulation is really only effective until about 60 kilos or 120 pounds. And so instead, we really focused on optimizing our orders so that someone can go in and write one order for the first dose and then 2 more doses as needed for the patient. So that way the nurse can just continue giving medications. The other thing that we did was individualized plans. So our adults really have the medication and the dose they decided on with our hematologist, but the ED providers can see, and I'll show you that in a moment. So it makes it it takes the guesswork out. What is the medication I should give? How much should I give? Instead of scrambling around and looking through the charts, it's right there for you. For our adults, we start patient-controlled analgesia in the ED to avoid the lapse. Since we're just down the hallway, we share PCA pumps between our sides. And then if someone is coming to the ED frequently, we have care coordination or social work. Sometimes patients are coming in, they were in the another ED the day before, and perhaps they were treated poorly, or they were treated with inadequate doses and they come in this time. And so someone can sort of tease that out versus some patients we found out are actually homeless, right? They're couch surfing. They have nowhere to go tonight. And so they come to the ED because at least they'll be taken care of. And by the way, if you're homeless, that's really stressful and it's going to cause a lot of pain. And so this is where this is just a mock-up from 2017 of our ED tracking board. It looks a little bit different now, but not that much. And you can see this is just a list of patients that I blocked out. And these FYI flags, this is where the patient care plans sit with the medication and the dose and a bit about the patient, what kinds of history they've had in the past, complications. But everyone can see this, nurses, providers, everyone, so that they're all on the same page about the medication and the dose. And they can all check to see, what is going on with this patient, because that's the most important thing. As soon as the patient is registered, this flag pops up. So from the time of triage, the nurse can see, oh, this patient has sickle cell disease. We need to get them in to a bed as quickly as possible. Now, I was talking about individualized doses for adults. I am not going to spend much time on this slide because Dr. Tanabe is going to speak with you in an hour. And this is her research, but there is some information that says that if we tailor our treatments to the patient, better things happen. And attitudes. This is a big problem. As I was going through that previous slide, a whole scale was developed saying that providers have negative attitudes. And so, this was a survey done 10 years ago, but honestly, I don't think there'd be any change between now and then. The negative attitudes were much more common in adult providers than pediatric providers. It actually, ironically, was much more prevalent in those who saw patients more often, once or more times a week, versus those who saw them much less frequently. White providers had more negative attitudes, and this is where the issue of race is a big deal in medicine, and we need to own that and address it. And then it was not associated with the age of the provider, if they're male or female, whether it was a teaching hospital. Ironically, the presence of a sickle cell center of excellence did not influence their attitudes. And I think that speaks to that big divide between the outpatient setting and the inpatient and ED settings, or the availability of follow-up services, right? So the ED is too often acting like an island unto itself. But these attitudes, can change. And so this was a study that was done with emergency department providers. They watched an 8-minute video. And this is the same, these purple, blue, and red bars are from the scale that I showed earlier about negative attitudes, positive attitudes, and the red flag, as they call it, attitudes. And so what they did is they watched a video. So they did the survey before the video. And then after the video, you can see that the purple bar went down, the blue went up, because that's positive, and the red bar came down. Then they repeated it 3 months later, and those change in attitudes held. I will say I did not publish this work, but I did work with interns that were in the hospital for 5 years. And we would do very similar things in terms of training patients, basically training the residents what is sickle cell disease. We would talk about, some of the complications, and then I would show them that video. And then we would talk about case studies, and it was very powerful. Because in that video, people are talking about their negative experiences, having to dress up to look presentable, to beg nurses to give them the medication, but they're ringing for it at 1.5 hours because they don't think they're going to get there at the 2-hour mark. This is what we need to fix. And finally, I'm just going to talk briefly about some national activities that are going on. And so in particular, the Emergency Department Sickle Cell Care Coalition. So I co-founded this coalition back in 2015, and Dr. Tanabe has been an inaugural member and very sage mentor to me during this whole time. And so we are a group that has recognized that there's a pressing need to improve emergency department care for individuals living with sickle cell disease, especially adults. It's a national coalition that's led and supported by the members of the emergency medicine community. We have to do change from within. And this support and leadership is needed to make progress. Who are we? So we've had the support of the American College of Emergency Physicians since the beginning, and they've been incredibly wonderful in terms of getting the message out about sickle cell. The Emergency Nurses Association has also been a staunch supporter and is also working very closely with us on various initiatives. The American Society of Hematology has been a wonderful partner, as well as the American Society of Pediatric Hematology Oncology. And you can see then we also have sickle cell specific organizations, including SCDAA, we have the CDC, and then we have the NIH, HRSA, and the Joint Commission has been a member of our organization and continues to be as we look to see and as we get more research to develop quality measures that potentially they can start measuring hospitals on in the future. So we've been doing a lot of work. At the beginning, we really were focused on spreading the word, giving talks at various ACEP venues, whether they're regional meetings, national meetings. We were talking to so many people, as many as would let us there. We did a little bit of research on ED physician attitudes, as well as the tools that they use to manage sickle cell pain so that we can really get in there and ensure that the tools that they are using are current and correct. And we actually are developing our own tool. So the American College of Emergency Physicians actually has a website where it's freely available that you can go on and see what do they recommend to take care of things like atrial fibrillation, or if someone is elderly and comes in with confusion and agitation. You can click on these tools and they give you ideas of what kind of tests should you run on these patients and what kinds of treatments should you provide. Sickle cell disease is coming next month. And so there's going to be a little box down here called SCD, Managing Sickle Cell Disease in the ED. And so this is, we just created it. We're looking at mock-ups right now, working with IT to finalize, and it's coming for Sickle Cell Awareness Month. But the EDs are only the beginning, right? As I go back to that fractured setting that sickle cell care is currently being provided in, we can't do it alone. We have to work within different agencies. And so we've actually had 2 summits. COVID has definitely disrupted our pace of summits, but before COVID hit, we're having them annually. And the
Dr. Kavanagh,
yes.
I'm sorry, I don't want to interrupt you. I just wanted to thank you for your amazing information and just let you know you have about 10 minutes left.
Perfect. I have 2
Thank
slides.
you.
So yeah, I've actually been timing myself. So the participants were sickle cell disease organizations, specialty organizations, as well as federal agencies. And the specialty organizations included ED providers, pharmacists. As I say, some of our key work was with pharmacists and hospitals, the American Hospital Association being one. And so what can organizations do? So number 1 is really recognizing the importance of the patient voice. We must integrate their perspective to really impact their own care. The second, we must increase awareness about sickle cell disease. Too many of us have learned very little about the condition and really do not appreciate the spectrum of complications. We need to develop easy to use tools, and hopefully this one tool that I just showed you will help us along that journey. And finally, we really need to bridge the continuum of care. So we really need to, ideas around that could be really having individualized care plans for every individual living with sickle cell disease. So there's no question around the medication and the dose. Promote messaging between ED providers and their outpatient providers. The electronic health records are really powerful. And so we should be able to do that much more easily, even across hospitals. Some states are further ahead than others, but this is coming as well. So the takeaway points from my talk today are really that we need to raise awareness around sickle cell disease. It's rare and in an underserved population and has been frankly neglected. And we need to do better here. The ED plays a very important role, and we should be there. When you're having an acute complication, we should be able to rely on the ED to provide high quality, excellent care. And too many times it fails. But there are tools that are coming into play that you'll hear more about today that really can help towards the goal of delivering high quality care. We need to improve care across care settings. We need to coordinate better. Inpatient, outpatient, ED. We need to just talk to each other. Also, we need to talk to each other across organizations as well. Share our knowledge, share our experiences, so that federal agencies understand where are the important, exciting mechanisms with which to treat people. What should they be promoting and supporting with research grants? And then community groups. What are some of the things that really are beneficial? And just sharing that widely through talks like today, very helpful. And I think everyone in the audience, hopefully through not just me, but really this whole afternoon, you will learn things that will help make a difference for children and adults living with sickle cell. Does anyone have any questions? I apologize. I think I've lost. Oh, there.
If there are no questions, I'm going to thank Dr. Kavanagh for excellent presentation. I have a whole list of takeaways. She summarized them there in her last slide, but I'm hoping everybody has their own list and can start to look at ways to make changes within your own practice. Again, thanks so much, Dr. Kavanagh. I've got several chats back here saying how excellent your presentation was, and I wholeheartedly appreciate you doing this for us.
Not a problem.
Okay. So if you have questions regarding her presentation, go ahead and put them in the chat and we'll see if we can address them later. Hold on, we have a question right here. How can we get our EDs to utilize these valuable tools?
So I think this is where, yeah, so I think this is where spreading the actions and experiences of EDs who have been doing this successfully is really the way to do it. In my experience, both with children and adults, we really need the hematologists working with the ED providers. because the hematologist works with the individual to create the plan, and then they need to put it in a place where ED providers can find it. Forgive me. When you have 15 or 20 patients at one time, that's why I love our plans being on the tracking board. You can't ignore it, right? It's staring you in the face. And other, programs have it, care plans in an obvious place as well. And so, all right, and I see the question, does my ED max the number of IV doses to 3? The answer is no, no. So we do 3 and then we see where we are. So if a patient says to me, because this happens all the time, like sometimes they only need 1 or 2 and they feel much better and we stop. If we give 3 and they say, you know what, can I just have like another dose, another hour, let's just see where we are, because I feel like I could turn the corner. And so that is very powerful. So no, there is no restriction. It's much more of a guide, that the expectation is that most patients will receive 3 before you make that decision, but it is not a mandatory or a restrictive number. And
We have another question. I think we have time for at least one more.
And this is where there's a question, have I had issues implementing pain plans in ER where the EMRs are not linked? And so when we first started doing our work in the adult side, I'll talk, because for children, it was a standardized protocol. There were no individualized plans. So it was all based on a weight. And we had a protocol placed within the pediatric ED website, as well as a pain calculator, a pain medication calculator, which made it much easier to calculate the doses. For the adult side, it was not linked, but the FYI flag was there. And so our hematologists, we are lucky in that we have one institution with hematology as well as the ED. So it's not across institutions. I think I'm going to save that for Paula, Dr. Tanabe, to talk about cross institutions, because she has some information about research that's going on about that. The final question, if I have time for one more, what are some plans or advice for patients that don't handle pain well or have trouble verbalizing? So this is a big point. When you're in severe pain, sometimes you cannot speak, right? And so in our point of care tool, we actually have a section to really talk about that caregivers are there to really help, right? So number one, if a caregiver is there, have them help you answer some of the questions. The second thing is ask the minimum number of questions you need to get the treatment plan started, right? So what medications have you taken at home? Have you had a fever in the last 24 hours? The number of questions is about 4 or 5. Then start the treatment plan. Get the first dose in. Get people feeling a little bit more comfortable. Then go back and ask a lot more about some of the more detailed history about, what medicines do you take all the time? Have you had surgery before? That's not crucial to starting the pain. So we're in the point of care tool, we're really trying to support patients who in severe pain who cannot speak, so that you get treated. And then we ask only the most critical questions, which are often yes, no, or a little bit easier to answer, and then go into the more detailed ones later. I don't know if that answers your question, but I think it's Lakeisha.
So Dr.
Okay.
Kavanagh, this has been an amazing, amazing presentation. I really do appreciate that. So if we have any more questions that do come in, I will make sure that we get those to you to get answered and get back to our audience. So again, I appreciate you making the time. I know you had another call this morning and you ended that early. So I appreciate that. So thank you. And I will go ahead and end this recording.